So we have the first question. Without further ado, let's crack on with it. We have got a 64-year-old man that presents to the GP with sudden onset pain and swelling at the base of his right thumb. And on examination, the first metacarpophalangeal joint was warm, swollen, erythematous. He's got a past medical history of chronic kidney disease, duodenal ulcers, and osteoarthritis in the knee. He drinks about 3 beers a day and has got a 20-pack-year smoking history. When you examine the patient's afebrile and has got no other symptoms. The question is asking you, what's the most appropriate management for this patient? Do you go for ibuprofen? Do you use colchicine? Do you use prednisolone? Do you use indomethacin? Do you use paracetamol? Have a think, guys. Have a think. I'll give you about 30 seconds to have a think. So we've got a 64-year-old man that's come into the GP, sudden onset pain, right thumb. Okay, sudden onset pain, right thumb. Have a think. First metacarpophalangeal joint, warm, swollen, erythematous. Note his medical history of CKD, duodenal ulcers, and osteoarthritis in the knee. He is a drinker, 3 beers a day, and 20-pack-year smoking history. Afebrile and got no other symptoms whatsoever. What's the most appropriate management? This is an apply type question in the sense that the examiners assume you know the diagnosis based on this, and then you can apply it so that you can give the right answer in terms of the management. Do you do A, ibuprofen, B, colchicine, C, prednisolone, D, indomethacin, or E, paracetamol? Let's go through the answer shortly. If you've chosen the answer colchicine, well done. You've got the answer spot on there. Now, firstly, let's just go through one thing at a time for this question, okay? And try and work out each of the options and why colchicine is correct answer. Number 1, the acute onset, pain, swelling at the first metacarpophalangeal joint of the right hand, of the right thumb, combined with the patient history of excessive alcohol consumption, and CKD points towards a diagnosis of gout. And gout, we're going to go through it in a deeper detail in a bit, is a crystal arthropathy, which presents with a unilateral acute inflammatory arthritis due to very high uric acid levels. Okay? The first line treatment of gout is going to be NSAID. However, this patient has got CKD, and thus this is a contraindication. That's why colchicine is the agent of choice, okay? Because it will reduce inflammation, reduce swelling caused by the uric acid crystal deposition. Now, why not ibuprofen? A lot of you would have recognized that this might be gout, this might be something that needs anti-inflammatory. They may have chosen ibuprofen. Well, read the question. The question says CKD, and obviously an NSAID, which is normally a first-line treatment for gout due to its anti-inflammatory properties, will be contraindicated for these patients with duodenal ulcer, with CKD as well. Okay, so bear in mind, these are contraindications. Now, what about prednisolone? Well, some people do choose prednisolone, okay, and they do like to use it because sometimes steroids are used to treat acute gout attack, and they are considered after NSAID or after colchicine if ibuprofen and colchicine are contraindicated too. Okay? And only if they're contraindicated. Whereas in this case, there's no such contraindication. Now, what about indomethacin? And again, indomethacin is also an NSAID. And obviously, again, there are contraindications, gastric ulcers, etc., including CKD. So bear that in mind. Paracetamol. So why not paracetamol? So this patient's got a CKD. You're not going to give an NSAID. What about paracetamol? I hear you ask. Well, paracetamol is a very effective analgesic for pain relief, but it lacks the anti-inflammatory properties. So it's not going to suppress the inflammation caused by uric acid crystals in gout. So the answer is B, colchicine. Gout is probably one of the most common tested topics in rheumatology that you're going to get, okay? I wouldn't go through some of the nice guidelines that relates to acute gout, which is one of the most common inflammatory arthritis. Now, gout is going to be diagnosed clinically. It's based on the following presentation. So the rapid onset, severe pain. Often when I say rapid, it means overnight. That's the speed at which it comes on. There was no pain before, and there is sudden pain, so much so that you might not be able to wait there. There is redness, there's swelling, and is commonly in the first metatarsopharyngeal joint, or presents as tophi. It could be in other joints as well, okay? Don't get me wrong. It's not just in the thumb base. It's not just in the big toe, which is the first metatarsopharyngeal joint. It's also in other joints as well. So the ankle, the knee, the hand, the wrist, the elbow, the midfoot, what we call the bootlace area, the area where you tie your shoelace, the midfoot area also can be affected. Now, when people say rapid onset, severe pain, often people think, oh, what about septic arthritis? Could it be septic arthritis? Well, obviously, in the case that we saw in the last one, that chap had no fever. So he was afebrile, no other symptoms. Whereas with septic arthritis, we'd expect to have an element of systemic response, including fevers. Obviously, if there is a diagnosis is uncertain, then you need to refer to secondary care for joint aspiration plus minus imaging and same-day blood tests as well. Now, I hear you ask, what about serum urate? Is that helpful at all? Well, SUA, serum uric acid levels, can be helpful. So during the clinical presentation, if it is acute gout and you think it's acute gout, and you measure the serum uric acid level as over 360, then the diagnosis is confirmed. Okay. However, if you do it during the acute flare, but it's actually less than 360, it doesn't mean anything. It doesn't exclude it, because during attacks, the level could be normal, could be high, or could be low. You have to repeat it 2 weeks after the flare. The diagnosis of acute gout normally is a clinical diagnosis. Bear that in mind. Now, why is that important? Because I'll show that later when we come to long-term management. Now, the acute management of gout, as I elicited before, is going to be NSAIDs, colchicine, or a very short course of prednisolone. It's all based on the patient's comorbidities and what they can tolerate. Now, obviously, if someone's got NSAIDs, someone's got oral corticosteroid, you may want to consider giving a PPI, okay? And if you do give colchicine, remember that sometimes it is gastrotoxic. It can cause diarrhea as the most common side effect in terms of toxicity, okay? Now, obviously, if they don't tolerate NSAID, don't tolerate colchicine, think about giving corticosteroid, either IM or as an injection or as an oral prednisolone. Just bear that in mind. Obviously, patients can use other methods to reduce pain, ice packs, etc., and not non-weight bearing, things like that. Now, what about in terms of longer term management? How are you going to manage someone who's got gout or someone who's got acute flare-ups of gout? That's a good question. The longer term management of gout basically is to offer something called urate lowering therapy, ULTs. And these can encompass things like allopurinol or febuxostat. And often you offer these to patients who, if they have a preference, for example, if they've got multiple flare-ups, if they're in CKD, stages 3 and above, if they're on directed therapy, or they've got tophi already. These are patients who are at high risk of having this again. We need to decrease the uric acid. And we normally start it around 2 weeks after the flare has settled down. Otherwise, if you start it too early, it's going to cause another flare-up and potentially elongate the current symptom of acute gout attack. Now, if you were going to start a uric acid lowering therapy, you were aiming for a target of less than 360, and you would monitor it on a monthly basis. However, if this is an acute gout attack that comes again and again and again, ongoing flare-ups, or they have tophi, then you'd consider aiming for a more stringent level, a stringent threshold of less than 300. Okay, so bear that in mind. Now, obviously, if it's stable, you consider annual monitoring of serum uric acid levels too. So that's the short-term management, and more importantly, the long-term management, which is an examiner favorite. I just wanted to show you some photo of advanced gout. So you can see tophish gout. This is gout with lots of tophi, with multiple intra-articular and peri-articular, so in the joint and around the joint tophi, and you can see that in picture A, where we have on the big toe, on the first metatarsophalangeal joint, as well as that on B, which is also on the hands with severe tophus gout. You can see the swelling, you can see the redness, and you can imagine this is severe pain. This is very much advanced disease.